सर 1 मिनट स्टार्ट कर रहा हूँ सर थोड़ा।
Sir, shall I start the class? Okay, sir, I'm starting the class. Sir, I have tried to compile, means try to dissect most of the ataxic part. Means mainly will be today will be dealing with approach. So coming to the ataxic disorders. So ataxia is there is no, means the patient has no control of body movements. So this is known as in a brief word what does that ataxia means. So coming to the symptoms of cerebellum, so it includes titubation. That is, patient is having yes or yes no. That is, head nodding will be there. Patient will be having particular head nodding because of the cerebellar disorder. And some patients have hypotonia. Some patients have pendular near jerk. Some patients have intentional tremor. They have dysmetria. Dysmetria is patient is not able to particularly perform finger nose test or finger nose finger test. So there will be pass pointing here. Dysenergia is patient is unable to perform the coordinated movements. Means patient will have like a breakdance like movement. So the patient will break down the a particular movement into multiple compartments. So it will look like a breakdance. So other is dysdiadokinesia. So alternating when you ask the patient to flex, pronate and supinate the arm, then the patient will not be able to perform properly. Another is rebound phenomena. So in this rebound phenomenon, you ask the patient to flex the arm so that you protect the front. You ask the patient to try to bring the arm towards his body, and you resist that by your hand. So when you leave the hand, the body automatically body will try to control it. But in cerebellar disorders, patient will directly slap his face or slap his body. This is called as rebound phenomenon. And some patients will have nystagmus also. So coming to the cerebellar anatomy, the cerebellum it can be divided into archicerebellum, paleocerebellum, and neocerebellum. So archicerebellum is vestibulocerebellum, paleo is spinocerebellum, and neo is cerebrocerebellum. So cerebellum is connected to the brainstem by 3 peduncles, and the 3 peduncles are superior middle cerebral peduncle and inferior cerebral peduncle. Particular to medulla oblongata, middle cerebral peduncle to pons, and superior cerebral peduncle to midbrain. So vestibulocerebral peduncle here. Here the patient it is the oldest part of the cerebellum. Like the patient it has one deep nuclei, that is vestigial nuclei, and in cerebellum majorly two, the patient will have input and patient will have output fibers. The input fibers for the flocculoorbital lobe or the vestibulocerebellum is from the inferior olivary fibers. So it passes through inferior cerebellar peduncle. So and they climb up to the gray matter inside the cerebellum, and hence these fibers are called climbing fibers. So the output fibers here are from the usually the output fibers from all the cerebrum is from the nuclei, and the vestigial nuclei will supply uh, here to the vestibulospinal tract, and this will go downwards as vestibulospinal tract. This is vestibular nucleus, and this will go as vestibulospinal tract. So this will maintain the extensor tone and maintains the balance. So vestibulospinal cerebellum as a whole, to tell the function is to maintain the balance. Coming to the spinocerebellum, here the patient receives the input fibers from the spinal cord. And where are the fibers coming from the Golgi tendril organs, from muscle spindle, from the Pacinian corpuscle? All the sensory symptoms will go here and will reach to the inferior cerebellar peduncle to the cerebellum via this anterior and posterior spinocerebellar tract. And the particularly from the upper limb, it the fibers go to the nucleus cuneatus, and these fibers go to the cerebral through the inferior cerebellar peduncle. And here the spinocerebellum has two nuclei, that is emboliform and globosis. So these two nuclei will give out the output fibers. The output fibers here, they give rise to two tracts. So it supplies the thalamus once, and it supplies the red nucleus. So it will go down as rubrospinal tract, and which is responsible for gamma motor neuron activity, which controls the intrafusal fibers in the muscles. Coming to the neocerebellum, the input is mainly from the brain as cortex. So through the cortex, it will end up in pons. From the pons, it goes to the cerebellum through the middle cerebral peduncle. This is the input fibers. From the neocerebellum, it goes, and the output fibers are from the dentate nuclei. It goes outside superior cerebellar peduncle, and they supply to the same red nucleus, and it also supplies to the thalamus, and it supplies to the even cortex. These are the output fibers. It is from the dentate nucleus. So to comprise all the tracts as of now, like the patient is having from the cortex, the patient will from the cortex, the patient will receive the cerebellum will receive from pons through the middle cerebral peduncle to the cerebellum. It even supplies to the inferior olivary nucleus, and it supplies to the cerebellum. And some of the fibers go to the reticular activating system. It also supplies to the cerebellum. These are from the cortex. These are, and total there are 3 tracts. Coming to the from the inflow tracts to the cerebellum, from the spinal cord, there are total 4 tracts. One is, as we discussed, it was anterior spinocerebellar, which goes to the anterior and posterior spinocerebellar tract. Posterior spinocerebellar tract will directly go to the same side, and through the inferior cerebral peduncle, it reaches the cerebellum. Whereas the anterior spinocerebellar tract, it usually goes to the superior cerebral peduncle, and reaches the cerebellum tract, and other are from the nucleus cuneatus, which receives the fibers from the uh, upper limb, and lastly from the inferior olivary nucleus. These are the these are the supply from the spinal cord and vestibular apparatus. Coming to the four efferents, which as a whole are from, it goes from the dentate nucleus to the red nucleus. It goes to the thalamus and to the cortex. And from the red nucleus, actually it crosses the fiber on the opposite side, but again from the rubrospinal tract along with the corticospinal tract, it comes to the opposite side. Hence the cerebellum controls the same side tone, and even the fastigious nucleus will control the vestibular nucleus of bilaterally. And it also gives fibers to the reticular activating system. So total of 4 fibers. It goes to this fibers is called dentato-rubrothalamic cortical fibers, and it goes down as rubrospinal tract, and the vestigial nucleus supplies the vestibular nucleus, and it also supplies to the reticular activating system. And from the globosis and emboliform, which is both of them are called as interosposes nucleus, will supply the fibers to the thalamus also. These are the 4 referents. Coming to the ataxia per se, mainly there is problem in coordination. So patient will have input fibers from sensory, and executor will be the motor fibers and the muscles. So if patient is having ataxia or imbalance, basically it can occur in the input fibers. It can lead from the sensory or from the vestibular nucleus per se, or also called as labyrinthine ataxia, or coordination, which is coordinated by the cerebellum itself, can cause cerebellar ataxia. And another is Brunt's ataxia. It is type of an ataxia occurring. It is also known as frontal ataxia. We'll discuss this part later. Coming to the how to differentiate a cerebellar ataxia and peripheral vestibular ataxia. So patient here the patient also particularly will have nystagmus and gait imbalance in both of them, and the eye component will be over the slower side in the peripheral vestibular ataxia. But whereas the ENT symptoms will be present in the peripheral vestibular ataxia, here the peripheral vestibular includes labyrinth. So anything which is affecting labyrinthitis via or any tumor also, or if particularly infections. So if labyrinth is affected, the patient will have ear symptoms particularly, and the patient will try to avoid the vertigo. Patient will also have vertigo here. So how the patient will try to stop the vertigo by keeping the affected ear up, so that uh, the labyrinth as a whole is in stasis, so that there will be no movement. Hence the ataxia or vertigo symptoms will decrease. Whereas in cerebellar ataxia, there will be no ENT symptoms, and there is no particular side preference where the patient will keep the affected ear up, all those things. Coming to the central vestibular ataxia, means here the patient is where it is affected is in the vestibular nucleus. So the patient will here will not have any kind of ENT symptoms, even in the cerebellum and even in the central vestibular. But in the central vestibular, particularly, we see the brainstem reflexes. The brainstem symptoms. Means apart from the vestibular nuclei, other nuclei are also affected. Like nucleus could be affected, or in the region, any nucleus can be. So which will be usually absent in cerebellum if an isolated cerebellum disorder is present. Vertigo is usually mild here, and even vomiting is also mild in central vestibular, whereas it will be profound in the peripheral vestibular ataxia. So difference between the central and peripheral is the patient will have nystagmus in both of the patients, but the patient in the peripheral ataxia, the latency, the fatigability, and adaptability means the patient will have an inertia. Will try to when inertia is attained in the labyrinth, so the patient will adapt by itself. The patient also will have certain latency and fatigability, whereas in central nystagmus will not have any of these features. So particularly nystagmus, I'll teach in the future class. Means if we are taking, so like how to differentiate in sensory ataxia and cerebellar ataxia. So patient in sensory ataxia will have sensory symptoms, and particularly when you ask the patient to close the eyes during Romberg test, so the patient will have profound ataxia. The patient will have fall, and when there is particular wash basin phenomenon which will be seen in this ataxia. But whereas in cerebellar ataxia, sensory symptoms will not be perceived if there is an isolated cerebellar disorder. Whereas in Romberg's test, which is a symptom of an proprioception, which will usually not be seen in the cerebellar disorder, but sometimes can be present. Sometimes the patient can have also wash basin phenomenon because the patient, since the cerebellum is affected, the sensory inputs to the cerebellum is not being assessed properly. So multiple inputs it will be taking. If you remove any of the input, the patient will be receiving input from the eyes also, and all the position from the sensory position from all the joints also. So if we remove this, asking the patient to close the eyes means the patient, if it will be having less input, so still the patient can have cerebellar means the patient can have uh, the sensory symptoms might the cerebellar symptoms might worsen, and patient may have fall even in the cerebellar disorder. Coming to the gait, the patient will have broad based gait in the cerebellar disorders, whereas in sensory ataxia the patient will have high stepping gait, so the patient will not be able to perceive the land. uh, so patient is not aware that where is the land here, so patient will keep the is not aware how high so the patient will bring his limbs very high and will stamp the ground very hardly because he's not able to assess where is the ground at. So the patient will have state or hyping in sensory ataxia, whereas the patient will have broad based gaze in cerebellar ataxia. So as a cerebellar these are the symptoms of the cerebellar ataxia which we had discussed earlier. So coming to the frontal ataxia of the ataxia. So patient, there is a difference between cerebellar and cerebellum ataxia also. So the patient here both will have wide base gait. But what happens to the stride of the gait is it is affected. Since cerebral cortex is affected, that is the frontal cortex, which is predominantly the motor part. Here, since these fibers are affected, the patient will have will try to drag the limb, which will not be seen in the cerebellar disorders, because the patient functioning of the limb means the power of the limb is very low. So that's why the patient will try to drag the limb. uh, when you try to perform the heel shin test to the patient can perform in cerebral ataxia, but it is not able, patient will not be able to perform in cerebellar disease. Whereas tone will be increased in frontal ataxia, the tone will not be increased, instead it will be decreased in cerebellar ataxia. So postural instability will be more in the cerebral ataxia, because the controlling fibers are affected here, the executing fibers are affected, whereas the patient with cerebellar disorder will also have postural instability, which is very less. Coming to till now, we have discussed anatomy, cerebral features, and differentiating between peripheral vestibular, central vestibular, sensory, and cortex ataxia. So coming to the classification of ataxia, classification is clinically we classify the ataxia into uh, based on Greenfield's classification, which was modified by Harding. He has classified uh, predominantly the inherited ataxia and predominantly autosomal dominant ataxias to various types. So as a whole, the patient as a whole, the patient can be divided into pure cerebellar ataxia, spinocerebellar ataxia, and cerebrocerebellar ataxia. So in pure cerebellar, patient will be having core cerebellar symptoms. In spinocerebellar, patient will be having both sensory symptoms and cerebellar disorder. In cerebrocerebellar ataxia, where the patient will be having more often cerebral complaints, because the patient executing motor fibers are affected here. So as a whole, how to approach an ataxia. So we know we have classified into which type. We have come to a part where the ataxia is happening now. So now we have to note the mode of onset, means, and progression. So we have classified into acute, subacute, and chronic. And ataxia can be further classified into focal and symmetrical. Symmetrically affecting bilateral, focal if it is affecting unilaterally. So after dividing the attacks into symmetrical and or asymmetric, then we further classify into acute, subacute, and chronic. So in acute ataxia, where it occurs within hours to days, and the patient will be having uh, cerebellar symptoms. So it is predominantly due to intoxication, and it is due to drug induced, and which are usually correctable. And some will have viral cerebellitis. uh, I had seen one case of viral cerebellitis in first sem. Like the patient had typical swaying uh, whole of the body, means he was swaying a lot, and later CSF didn't reveal much, but it was supporting of a viral infection. Next, it can be due to post-infectious syndrome also. Post-infection patient can have immune-mediated acute cerebellar ataxia. In subacute causes, even it is due to intoxications by such as compounds by mercury, gasoline, and some chemotherapeutic agents and therapeutic agents. And vitamin B1 and B12 deficiency also cause subacute cerebellar ataxia. Even Lyme's disease can cause cerebellar attacks. In chronic, the patient will have where the symptoms will be from months to years. The cerebellar ataxia can be due to paraneoplastic syndrome, and particularly anti all this or the type of particular antibodies which are detected can have be seen in a particular paraneoplastic cerebellar degeneration. Anti-gliadin antibody, this is also positive in a patients with cerebellar ataxia. Even a patient with hypothyroidism can have cerebellar ataxia, and chronic, and it is progressing, and with a positive family history, then you will suspect inherited ataxias. And progressive progressive ataxia is also seen in the tapes dorsalis, that is tertiary part of syphilis. And some patients will, due to phenytoin toxicity, will have the progressive ataxia. So whereas in focal or cerebellar ataxia, which we can further classify into acute, subacute, and chronic. In acute, majorly it will be vascular causes and infectious, such as cerebellar abscess, which can be detected by the MRI or CT, means with supportive lesions. If the patient is having subacute symptoms, and usually if it is focal means if it is affecting unilaterally or isolated lesions, if you are seeing, then you'll suspect neoplastic lesions, sometimes demyelinating lesions like multiple sclerosis. Uh, it can be bilaterally also, but it can be focal and ipsilateral also in multiple sclerosis. And PMLE also can cause isolated or focal or ipsilateral cerebellar sign. Chronic cerebellar disorders include stable glasses, post-vascular lesion like after stroke, or sometimes the patient will have Arnold-Chiari malformations or Dandy-Walker malformations, which are noted on MRI or CT. These congenital lesions also produce cerebellar ataxia, focal or ipsilateral ataxia. So after knowing the causes of ataxia, we'll see how to approach the ataxia. So in approach to ataxia, we have to rule out basically the input, coordination, and output. The sensory, we have to rule out the sensory type of ataxia. We have to rule out if the patient is having any kind of an muscle disorder also, that has, and even any joint disorder also, patient can have an symptoms like ataxia, and which has to be differentiated and the coordination which will be affected in cerebellar disorder, and the output which is controlled by the motor fibers, and executing by the muscles. Here myopathy has to be ruled out, and motor fibers where ataxia we see, also called as frontal ataxia, which has to be differentiated. So, and other psychiatric causes include cataplexy, which has to be ruled out. After diagnosing it as an cerebellar ataxia, first we have to do the in workup, we'll do the blood investigations. And the first blood investigation which is important is vitamin B12 deficiency, vitamin E deficiency, vitamin B1 deficiency. That is thiamine, but the activity we should get it by testing the transketolase activity, but which we usually don't do. If a patient is having ataxia along with altered mental status with ophthalmoplegia, first we'll think of encephalopathy, irrespective of with a background history of alcohol. So usually we directly go ahead with treating with thiamine. Other like anti-glutamic acid decarboxylase antibody we'll test with the TSH also, and paraneoplastic workup, particularly if it is of subacute like presentation, and we do with the LP also to rule out infectious causes. Then we go ahead with doing the in imaging modality, particularly MRI. So in focal lesions, you will get an abscess, you will get an stroke lesions in the cerebrum. But the most common finding of ataxia in an MRI is cerebral atrophy, but which is usually normal in patient having Friedreich's ataxia. Friedreich's ataxia is a type of an inherited autosomal recessive ataxia. So we'll come to inherited ataxia later. So in these patients, the cerebellar atrophy will not be seen, though the patient is having cerebellar symptoms, and even AVID, that is ataxia with vitamin E deficiency, which is like an which presents as like Friedreich's ataxia, and some patient with A beta lipoproteinemia, which is a genetic variant of Friedreich's ataxia. These patients also can have normal cerebellum, and sometimes immune mediated, usually post infectious. These patients will have normal cerebellum, and some patient will have pontine atrophy with cerebellar symptoms. So we will suspect multiple system atrophy. If the patient is having predominantly cervical cord atrophy, then you'll think of Friedreich's again. So Friedreich's ataxia is like an inherited ataxia which predominantly affects the spinal cord, the dorsal root ganglion, and the large myelinated fibers, and even the corticospinal tract is affected. Though cerebellum it is affected, but is very unlikely to get affected, or it is if it is affected also, it will be minimal. The patient is having predominantly T2 hyperintensities in the middle cerebral peduncle without any lesions in throughout, or if you can suspect multiple sclerosis because the patient is receiving fibers from the cortex, pontine, then going to the cerebellum. These fibers, the myelinated fibers, will be affected. So isolated T2 hyperintensities in the middle cerebral peduncle, still you should suspect multiple sclerosis. And if the patient is having hyperintensities in the T2 hyperintensities in the mammillary bodies and in the paraventricular thalamus, so then you'll suspect a patient with a background of alcoholic history, will suspect Wernicke's encephalopathy. And the patient particularly having dentate nucleus calcification is particularly seen in SCAR20, that is spinocerebellar ataxia 20. So after ruling out doing the MRI, we'll come to an conclusion that the patient is having a cerebellar disorder with particular any etiology. Then we'll ask particular the family history. After doing the required ruling out all the acquired causes and all the diagnosable causes, none it is revealing, but with the positive family history of cerebellar ataxia in a family member, it can be further classified into autosomal dominant, autosomal recessive, and X-linked. So autosomal dominant ataxia are spinocerebellar ataxia, episodic ataxia, whereas autosomal recessive ataxia is further classified into based on the associated sensory symptoms. If the patient is having sensory symptoms alone, then it is further classified into Friedreich's ataxia. If the patient is having sensory plus motor symptoms, then we classify into the within with ataxia, the patient is having sensory and motor neuronopathy. it is under this ataxia, telangiectasia comes, and the ataxia with oculomotor apraxia comes. It is further classified into type 1 and type 2. If the patient is having autosomal recessive ataxia and patient is having no sensory symptoms, it is seen in autosomal recessive cerebellar ataxia only, and it is further classified into type 1 and type 2. They have associated elements. The spinal tract also might be affected in those. If the patient is having autosomal recessive ataxia with no sensory symptoms, and under this even Niemann-Pick disease also, type C, even these patients will have autosomal recessive ataxia with no sensory symptoms. X-linked ataxia, important one is which we have to remember is Fragile X ataxia syndrome. If the patient is having no family history, and if his age is more than 60 years, then you should think of degenerative ataxia. And under degenerative, it could be due to multiple system in atrophy. The patient here particularly we have multiple system atrophy. Cerebellar type will have this, like old age patient having both Parkinson features, cerebellar features, and patient along with that patient having autonomic failure symptoms like orthostatic hypotension, like urinary and bladder disturbances. And the particular even it has to Parkinsonism also has to be rolled out in a patient with having ataxia symptoms with no family history, now presenting in an old age patient. And another entity is like isolated sporadic cerebellar ataxia, and all other causes has been ruled out. We can attribute this to this entity. Coming to the inherited ataxia, spinocerebellar. Here, the particularly as the name suggests, the thing which is affected here is the spirocerebellar tract, which is predominantly affected. As we discussed, like the spinocerebellar tract has two parts, like anterior and posterior part, which supplies from the spine to the cerebellum, and it receives informations from all the muscles, Golgi tendon organs, and even from the joints. All the sensory information is obtained through this receptor. So it is more of a dry topic, like it is on most of the memory based, but I will try to cover most of the important points with which is like which we can write through exam. So in the spirocerebellar ataxia, we particularly encounter CAG repeats. The CAG repeats here encodes for the particular protein polyglutamate. So this polyglutamate protein will be excessively produced, and it can deposit in the nucleoli, or in the cytoplasm also. What it majorly causes is like it degrades the ubiquitin complex. This complex is necessary for the degradation of abnormal proteins or the proteins has been completed. So if this is the polyglutamate will affect the ubiquitin complex, then the degradation of the subnormal protein or the protein which is unwanted will accumulate, and that will lead to neuronal injury. This is the basic pathophysiology of spinocerebellar ataxia as a whole. Like particularly spinocerebellar ataxia can have symptoms from, as the name suggests, spine. We can include brainstem plus spinal cord. The patient will have peripheral neuropathy. We will deal into particular type of ataxia which will have the particular predominant symptoms. And as the name suggests, cerebellar, the patient will have the cerebellar symptoms. Apart from that, the patient will have also other pathologies affecting the cerebellum. Means cerebrum also will be affected. Even basal ganglia also is affected. So the patient predominantly will have spine and cerebellar symptoms. Along with that, patient can have pyramidal symptoms also. Patient can have extrapyramidal symptoms also. Along with the patient having peripheral neuropathy and the patient having the brainstem abnormalities where the patient pointer nuclei can be affected or the lower cranial house can be affected, and particular symptoms can be seen, like if 11 and 12, like particular dysphagia, patient will have the poor ability to cough and patient will have tongue atrophy. All this will be seen. So spinocerebellar ataxia will have cerebellar, brainstem, pyramidal, extrapyramidal, lastly spinal cord, that is peripheral neuropathy. And another important one which I forgot was ocular symptoms also. Some patients will have ocular stare, supranuclear gaze palsy and nuclear gaze palsy. All this will be seen in the spinocerebellar ataxia. Coming to the different types. The important one are 1, 2, 3 and 6, 7, 8, which is given in Harrison bit in a small paragraphs as a whole. So coming to the type 1 spinocerebellar ataxia, the patient here, the particular protein which is affected is ataxin 1 and which is located on the chromosome 6, and the patient will be having CAG repeats of 40. The patient will have cerebellar symptoms, pyramidal symptoms, extrapyramidal symptoms, will have brainstem symptoms like affect when lower cranial nerves are affected. Along with that, patient will have peripheral neuropathy also. The unique feature is here the patient will have autonomic symptoms also, like urinary and fecal incontinence, and the patient will have dementia also. And important feature here is the unique feature of type 1, it is the patient will have progressive past ataxia, like the patient symptoms will worsen rapidly in a type 1 spinocerebellar ataxia. Coming to the type 2, the patient here will be having affected the protein which is the gene which is affected is ataxin 2, and it is located on chromosome 12, whereas one it was chromosome 6 and the protein was ataxin 1. Here the patient will have cerebellar symptoms, pyramidal symptoms. Usually extrapyramidal symptoms will not be seen, and important point is the patient will have significant peripheral neuropathy in type 2 spinocerebellar ataxia. And the type 2 spinocerebellar ataxia is the most common type of ataxia in India. In most common type of ataxia overall is type 3. That is SCA3, that is spinocerebellar ataxia type 3 or Machado-Joseph disease, also known as Machado-Joseph disease. Coming to the type, the SCA3, which is also called as Machado-Joseph disease, here the protein affected is ataxin 3. Here particular CAG repeats will be around 60 to 84. In type 2, it was around more than 35 up to 70. The type 3 spinocerebellar ataxia is further classified into 3 types: type 1, 2, and 3. So based on this, the symptoms also will depend on the what type it is there. If in the type 1, the patient will have ALS, Parkinsonism type. Type 2, the patient will have ataxia alone. Patient in type 3 will have ataxia plus ALS symptoms. What is the important difference is in all the three, the patient in ALS type will have ataxia also, but it is less common. But ALS will be predominant. Patient will have Parkinsonism features, and patient will have symptoms like facial fasciculation, and the patient will have spastic gait. Patient will have clonus, both ankle and patellar. In type 2, patient will have predominantly ataxia symptoms. Along with that, patient might have ophthalmoplegia, of the ophthalmoparesis. In type 3, the patient will have sensory symptoms also, and the patient will lose the diaphragmal reflexes. One thing which we have to keep the important for here point here, it is the type 2, it is affecting young age group, like around 20, whereas type 3 we see it in 50 to 70 years decade, the 5th or 7th decade. That is about the spinocerebellar ataxia type 3. So 1, 2, and 3 are completed. Next left out is 6, 7, 8. Here the CAG repeats is not seen in the type 6. Instead, the other protein which is affected here, the other gene which is affected is CANA1A. The same gene is affected in the familial hemiplegic migraine. The same gene is affected in the episodic ataxia in the type 6 of episodic ataxia. So in the familial hemiplegic migraine, the patient will have missense mutation. Here the patient will have nonsense mutation. So in the spinocerebellar ataxia type 6, the patient will have both the same CAG repeats will be still there, like polyglutamate disease only, like polyglutamate accumulates and causes the neuronal loss here also. The patient will have predominantly cerebellar, also have pyramidal symptoms, but the type 6 is like slowly progressive. The type 1 was the fastest one, which was rapidly progressing. Type 2 is slowly progressive and has benign course. Type 7 is simple, like the gene affected is ataxin 7 only, located on chromosome 3. It is also polyglutamate disease with CAG repeats around more than 30. Patient will have cerebellar symptoms and pyramidal symptoms. And important features here, it is the patient will have visual loss. And patient will have seizures also. in type 8, the patient will have the gene affected is ataxin 8 on chromosome 13, but only difference from all of this, it is in CTG repeat. So patient will have both here cerebellar, pyramidal, extrapyramidal symptoms. Patient will have cognitive symptoms also. So to summarize, type 1 will have all symptoms, and it is progressive and it is very fast. And unique features are like the patient will have cognitive dementia and associated autonomic features. In the type 2, it is most common in India. Here the gene affected is ataxin 2. Patient will have cerebellar and pyramidal, but less likely extrapyramidal. But the important point which has to be noted is peripheral neuropathy. Type 3, which is also called Machedo-Joseph disease. Here the CAG repeats is around 60 to 84. It is further classified into type 1, 2, and 3. And type 1, it is ALS Parkinson type. Type 2 is ataxia prominent type. And type 3 is even the patient having ataxia sensory and ALS type. Type 6, it is also polyglutamate disease, but the gene affected is here is CACNA1A. Means the gene which is the protein which is affected here is voltage gated calcium channels. And particularly of alpha 1 subunit, here it will be affected. So these proteins, due to affection of this particular voltage gated channel, the patient will have the type 6 ataxia. It is slowly progressive. Patient will have benign course. Type 7, the patient will have particularly visual loss and seizures. Type 8, the patient will be the main difference is CTG repeats. Rest all symptoms. Like if you are writing short notes for spinocerebellar ataxia, we can include cerebellar, pyramidal, extrapyramidal, oculomotor, and peripheral neuropathy as a whole. Along with that, particular types as type 1 as like it is fast progressing. Type 2, it is most common in India. Type 3 is most common in all over world. Type 6, 7, 8. Here another protein is different protein is affected, that is voltage gated calcium channels. Type 7, it is also fast progressing. Along with the patient will have visual loss plus seizures. Type 8 is different from all of this. It is CTG repeats will be seen. Rest all will have CAG repeats. This completes the spinocerebellar important ataxias. Like another attacks disorder with polyglutamate accumulation is dentato, rubro, pallido, Lucian trophy. So here the atrophin 1 gene is affected, and the patient will have here also CAG repeats. There is polyglutamate accumulation. Hence, the patient will have cerebellar, pyramidal, extrapyramidal, and the important one here, the patient will have chorea also. Some have myoclonus also, and seizures also, which we had seen in the SCA7. And it is prevalent in Japan. This dentato rubro-pallidoluysian atrophy. They have even these have the genetic anticipation property. So as a whole, another important point which I forgot to tell was genetic anticipation is seen in all types of spinocerebellar ataxia. In type 6, it has a benign course. There is no spinocerebellar ataxia 9 and spinocerebellar ataxia 23 is not part of autosomal dominant. Instead, it is autosomal recessive. We have completed the important spinocerebellar ataxias. Next will be dealing with the episodic ataxia. Episodic ataxia were type 1 to 7, but the important point which we have to remember is types which we have to remember is type 1 and type 2. So here the patient will have cerebellar symptoms. All this and it is autosomal dominant, and the particular gene affected here is KCN1A gene. And the patient will have muscle twitching particularly. With all these, patient will have muscle twitching, myokymia, myotonia. So this cerebellar, this are episodic. So the patient will have episodic symptoms of ataxia and will have intermittent type. So this ataxia intermittent type, which is usually triggered by doing exercise or when the patient is hyper excited, like elated mood, or when he's excited. So all this will trigger this episodic ataxia type 1. In type 2, the patient will have the symptoms for 30 minutes to 6 hours. Patient will have all the symptoms of cerebellar disorders like instability in the dorsum, the dizziness, fatigue, and the patient will have nystagmus also. Here, the gene which is affected here is CNA1A gene, the same gene which had affected in the SCA6. Even the same gene is affected in episodic ataxia type 6. The patient will have familial hemiplegic migraine. In episodic ataxia type 6. So these are the important points about episodic ataxia. Coming to the most common cause of inherited ataxia and which is autosomal recessive is Friedreich's ataxia. Friedreich's ataxia, here the gene which is affected is frataxin gene. So frataxin gene produces a protein which help in the taking out the iron from outside of the mitochondria. So if the gene is affected, there is iron accumulates, and the oxidative phosphorylation process will not take place in the mitochondria. Hence, the reactive oxygen species will be further accumulated, and this will cause neuronal damage. So what is the site it predominantly affects? It is not cerebellum here, but instead spinal cord. In the spinal cord, it affects both motor and sensory tracts. It affects posterior column. It affects the corticospinal tract. It affects the dorsal root ganglion. And it even affects the peripheral neurons. So there are types of Friedreich's ataxia. Not types, the variants of ataxia, the Friedreich's ataxia. One is the classical form. where the patient is having a frataxin gene which is affected. Another is A beta lipoproteinemia, also called as Boson-Konsvig disease. Or syndrome. Another Friedreich's ataxia with vitamin E deficiency. So in this type, the majorly the patient will be having deficit of vitamin E. Vitamin E is like an reactive oxygen species scavenger. So here this vitamin E will be affected, means the patient will be not having the vitamin E in the peripheral tissues, because there is problem in the transport. So in this beta lipoproteinemia type, like the patient will not be able to produce proper VLDL, and VLDL will carry the vitamin E. So particular mutation in microsomal triglyceride transfer protein will lead to this kind of an Friedreich's ataxia. Friedreich's ataxia with vitamin E deficiency, particularly here the alpha tocopherol carrier protein is affected. So there is impairment in the inability of the vitamin E vitamin E will not be able to bind to the VLDL. So hence it will not be transported to the peripheral tissue. Hence the patient will be having no vitamin E. So that's why the patient will develop ataxia. So if we correct with the alpha tocopherol externally, the patient symptoms might reverse sometimes. So we read particularly about the CNS manifestations, that the patient will have cerebellar, the spinal, the corticospinal tract will be affected. The patient will have extensor plantar. The patient will have hyperreflexia. Sometimes the patient will have extensor plantars which are extensor and hyporeflexia. Hyporeflexia is because of the loss of reflexes due to peripheral neuropathy, which is even because the peripheral neurons also are affected, and dorsal root ganglion also is affected in the Friedreich's ataxia, and this kind of combination also we will be seeing. And it is the usual combination which we see, like the patient is having extensor which is plantar, and patient is having hyporeflexia. Then we have to suspect Friedreich's ataxia, and also sometimes between B12 deficiency can produce this kind of picture. These are about the importance and others which is affect the tract which is affected is the posterior column. The patient will have loss of vibration sense and proprioception sense. The patient also will have weakness. Usually it is distal more than proximal. Coming to the age of presentation, like Friedreich's ataxia, usual age is less than 25 years, and there is a variant of this where the patient will be having Friedreich's ataxia more than 25 years. So in a patient less than 25 years with all the ataxia features, predominantly sensory type of ataxia, less of cerebellar symptoms, and along with that patient is having extra CNS manifestation. It can affect the eyes also. Some patient will have optic atrophy. Coming down, the patient in the heart can produce uh, hypertrophic cardiomyopathy. Some patient have conduction abnormality. So the patient lifespan last the fourth decade. In Friedreich's ataxia, because of the conduction abnormality, patient will have arrhythmias, or due to the hypertrophic cardiomyopathy, patient will have the cause of death in the Friedreich's ataxia mostly is due to the heart uh, problems. Other endocrine coming still down, like we have pancreas. The patient will have diabetes mellitus. There will be insulin resistance here, and other musculoskeletal symptoms which we see here are pes cavus, pes equinovarus, and scoliosis. So how do we diagnose this Friedreich's ataxia? So for diagnosis, patient less than 25 years with heart symptoms, patient having CNS symptoms, particularly like uh, ataxia, which is sensory, and some patient will having extensor, which is the plantar, which is extensor with hyporeflexia. All will be suspecting Friedreich's ataxia. When you do MRI might be normal, their cerebellum is spared. But when we come to the cervical cord, there is atrophy. So all this, like, it is clinical diagnosis only. Like the patient, you can further do genetic testing to confirm it. So how do we treat a patient of Friedreich's ataxia? So the important pathophysiology which is seen in the Friedreich's ataxia is there is increased reactive oxygen species, which is causing neuronal damage. So we need the scavenger of this. Either we can use vitamin E. Usually all Friedreich's ataxia patients are given. Some patients do respond with vitamin E, and that variant type is with we had already discussed, like patient having ataxia with vitamin E deficiency. Another scavenger which we use is idebenone. So this drug also removes the reactive oxygen species. Uh, it is given on 5 milligrams per kg per day, and usually it has not much effect on CNS manifestation, but improves the cardiac activity overall. Patient mostly will have a GI side effects when we give this drug. And another, like iron chelator also has been tried, but it has not shown much of the benefit. So this completes as a whole, like we discussed the cerebellar anatomy, symptoms of cerebellum, spinocerebellum and neocerebellum. I shall give the notes also. Means I have made some notes like particular to the cerebellar anatomy. Once you can see those, it will be further more clear. And we have differentiated further type of ataxias, and rest these were the we had discussed about the spinocerebellar ataxia, episodic ataxia, and important one is Friedreich's ataxia. Okay, what is the cutoff age after which you should avoid a diagnosis of Friedreich's ataxia? Uh, they usually die by 35 years. Means roughly they give like 4 decades, and usually symptoms are seen by. And one thing which I forgot is like a response to the acetazolamide. In type 1 there is variable response, in type 2 their response.
Thanks, Gagan.
Okay.
हेलो गगन, मैं कुछ बोलूं?
हाँ
या
सर,
सो
हाँ सर, हाँ सर।
फर्स्ट थिंग इज कि जो तुमने रीबाउंड फिनोमेनन का बोला ना कि यू सेड कि द रीबाउंड फिनोमेनन इज प्रेजेंट, पेशेंट विल हिट हिज बॉडी और फेस. नो,
हाँ,
जो इट इज डिस्क्राइब्ड दैट वे बट इट एक्चुअली डज नॉट हैपन दैट वे, है ना. सो उसमें क्या होता है, इफ यू वांट टू सी हाउ रीबाउंड फिनोमेनन लुक्स लाइक, जस्ट एग्जामिन द लेफ्ट हैंड ऑफ योर फ्रेंड्स. ठीक है.
ओके.
सो जो तुम्हारा बैचमेट होगा उसका राइट हैंड में रीबाउंड चेक करो, लेफ्ट हैंड में चेक करो. द लेफ्ट हैंड जैसा भी उसका रिस्पॉन्स होगा दैट इज रीबाउंड पॉजिटिव. सो यू वॉन्ट गेट is that archeo. So this is the sequence. So in evolution what happened, so the organism started to stand first, है ना. So first हो गया standing, keep maintaining balance. So
Okay.
first जो आया था that was vestibular cerebellum, fine.
Yes, sir.
Then organisms start to move around. So that was involvement of your spinocerebellar tracts. So वो हो गया paleo. And later on, like humans and other later organisms started to plan and evaluate the sensory inputs. वो हो गया तुम्हारा neocortex. So this is the sequence of development. Next is कि ये बताओ, nystagmus is the most important sign of cerebellum, right?
Yes, sir.
So what is the pathogenesis of nystagmus? Simple कि if examiner asks you कि nystagmus होता ही क्यों है, why does nystagmus happens? Tell me in one line.
Sir, like there is an supply from there are two supplies
Incoordination of
from the
eye
cerebellum
movements.
to the rubro red nucleus. From there the third cranial nerves arises. So that can be one reason, sir. Another reason, like the vestibular.
This is not a reason. If you were saying if that
Like-
tract is not working, then the third nerve will not work, you are saying. How does it cause
Okay,
nystagmus?
nystagmus. Okay.
Nystagmus is a fast component, as a slow component. So in simple words, how will you tell your examiner that what is the mechanism of nystagmus? Because this is a question which is also in exam. So basic funda is ki for keeping the gaze toward one side, you need a nucleus which is continuously firing. For example, if you're looking on the right side, you need a nucleus which is continuously firing the right-sided lateral rectus and the left-sided medial rectus. Okay. So there is tonic contraction of these muscles. There should be a continuous excitation coming to these muscles via nerves. If there is some issue with that particular nucleus which is sending the impulses, if the impulses are slowed down, let's say for example, so the duration between two stimulus will be decreased, and during that time the eye will try to go back to its neutral position. So the eye trying to go back to its neutral position is the slow phase, and as soon as the next electrical stimulus comes, it goes back to the fast phase. Okay, so this is the simple mechanism of nystagmus. This you should know. So the nucleus which I am talking about is called the burst generator. You can remember like that, है ना? Burst generator होता है, उसकी injury से nystagmus. Next is for practical point of view, what happens to the tone in cerebellar disease?
There will be hypotonia, sir.
Yeah. And what happens to the reflexes?
Reflexes, sir. Reflexes
normal,
are
sir?
not
Normal. Any specific sign in reflexes when you check cerebellar patients?
Pendular.
Yeah. So since there is hypotonia, there might be pendular knee jerk specifically. And pendular के दो mechanism है. One is की hypotonia है. Second one is की body does not know when to stop. So dysmetria. So pendular
Okay.
jerk is also a form of dysmetria on examination. फिर बताओ कि you told us how to differentiate central versus peripheral, vertigo or nystagmus on OPD basis, or if examiner asks you, tell me one clinical sign with which you can differentiate central versus peripheral. So which will be that one sign? Important one. Central
One is
versus peripheral,
just
vertigo. Mhm.
vertigo or vomiting, sir. That either of those. I'm guessing, sir. I
नहीं,
don't know.
central vertigo versus peripheral vertigo. How do you differentiate on clinical examination?
Means
If you're given only one test, so the answer is head impulse test. ठीक है? So you should do head impulse test. You can Google and find out what it is. It's very
Yes, sir.
easy to do also. And the next is, so always remember, all of you know that Rombox is a test for proprioception and not for cerebellum. And so
Yes, sir.
what instruction do you give to the patient when you are trying to do Rombox? Apart from key, you have to stand and without any support, you will close the eyes and we'll monitor you how you do. What is the instruction missing in this?
Legs should be kept together.
This is wrong.
And
Feet should
okay.
not be kept together.
Patient means
Hand will be
So
outside.
the feet should be kept at patient's comfort.
okay, sir.
So
Okay.
yeah, even in UG, even I was told ki feet should be kept together, but here all the professors, they are very adamant about this point in neurology. Ki if
Okay.
you keep the feet together, you are like trying to exaggerate the abnormality, whatever is there. So वैसा नहीं करना है. In whichever so the rhombus the funda is ki patient, there should be worsening, right? So patient should be absolutely fine, normal with eyes open. So you ask the patient ki be comfortable, keep your feet as far as you are comfortable with. Then you check for the worsening on eye closure. If there is already imbalance. Next is कि frontal ataxia. Gagan, तुमने बताया कि what is frontal ataxia, but I think even you are not sure what is frontal ataxia.
Means
Mm-hmm.
like particularly
So
the
you told
fronto
कि there is
ponto.
dragging of feet.
Yes, sir. Yes, sir.
Yeah, बोलो.
Means the reason for dragging of feet, like I'm not sure.
हाँ, so देखो जो frontal gate होता है ना, frontal gate is not because of your corticospinal tracts, है ना? This is not because of your weakness or anything. तुम ये बताओ what is apraxia?
Inability to perform the known motor movement.
Even when your sensory, motor, cerebellum, everything is normal, the patient is not able to do a certain activity. This is apraxia. So apraxia का reason क्या होता है? So in brain there are multiple centers. One center is storing the formulas of how to do the activity. Second center is there to transduce the formulas to the activity. If the transducer is not working, the formulas will not be converted into the action. So your frontal ataxia or frontal gait is basically a type of apraxia for walking. Simple.
Okay.
There will be normal sensory, normal cerebellum, normal power, but still the patient is not able to convert the formulas of how to walk into the exact signals. So ये तुम्हारा frontal gait. Next is जो SCA का तुम explain कर रहे थे ना, this much detail is only required for your MCQ exams. The funda is कि EGPGs को exam में case मिलेगा and they will definitely make a diagnosis कि slowly progressive pancerebellar disease which is hereditary. Differentials SCA. फिर EGPGs जो भी होंगे they'll find out कि यार मेरे patient में तो extensor plantar मिल रहा है ना? Is there another disease या corticospinal भी है ना? तो in SCA every patient will have some atypical sign which you are not able to you cannot explain with cerebellum. So you should only know कि SCA में if in a proper pancerebellar patient तुमको क्या sign मिलेगा, then what which type of SCA you will think of. India में सिर्फ ये याद रखो, there are 4 types mainly. So अगर ocular saccades और pursuits गड़बड़ हैं, it is SCA2, which is the most common in India, है ना?
Yes, sir.
If तुम्हारा extensor plantar आ रहा है और you are getting exaggerated reflexes, यानी basically ALS जैसे features हैं, it is 3.
हाँ sir.
है ना? If the patient's age is 50 plus and 50 elderly है, it is slowly progressive to 6, it is SCA6, and if tremors are there, तो it is SCA12. ठीक है? In Delhi, Gurgaon, Noida, SCA12 is the most common as per the AIMS studies.
Okay.
अब ये हो गया, ठीक है. और जो तुम बोल रहे थे कि SCAs में anticipation होता है ना, that is true theoretically, but almost 50% of the patients who come to ROPDs, they won't have family history. So absence of family history is not a way to rule out कि SCA तो नहीं हो सकता, है ना? Even with history, with family history, without family history, you always have to make a differential of SCA. Next is जो episodic ataxia का, you told episodic ataxia का importance is sometimes like 4 days back only I saw a patient who told कि पहले ataxia कम था, बढ़ता गया, and now he is unable to do anything. So the progression was not in the amount of imbalance, but it was in the duration. पहले उसको सिर्फ दिन में 1 घंटे होता था, and later on उसको पूरे दिन होना शुरू हो गया. So this is typical history of EA.
Okay.
Eventually all EA patients will develop continuous ataxia, but जो onset होता है, in that they'll have periods of intermittent normalcy. ठीक है. और Friedreich's ataxia का diagnosis तुम अगर differential बनाओगे तो patient से और क्या-क्या screen करना? There are 3 main diseases which you have to screen in Friedreich's ataxia if you are making a differential.
3 main extra diseases.
Associated diseases जो भी होती हैं वो बताओ.
Cardiac
associated with FA, Friedreich. हाँ, तो तुमको you have to ask about cardiac complaints and you have to examine the cardiovascular properly. फिर second,
patient will have sometimes cataract. Sorry, eye symptoms also might be there, sir. Patient, I'm not sure like which will be there.
mainly
Optic atrophy.
second is your skeletal deformities, है ना?
Okay,
as soon as you have as soon as you make a differential of FA, your examiner will go at the back of patient to look for scoliosis. And if scoliosis is not there, he won't be happy. Simple.
Yes. Okay.
और so scoliosis देखना है और foot deformities देखने हैं, hammer toe वगैरह मिलते हैं. उसका ये हो गया. और इसने this guy has told correctly, diabetes होता है.
Diabetes. Okay.
Yeah.
This guy.
है ना? So you have to screen for all of these.
Okay, sir.
I think that's it. बाकी तो you covered everything, I guess, for whichever is required.
Yes, sir.
I have a
Hello, sir.
table in which all the signs and symptoms of cerebellum and the exact mechanism is written together. So it looks good also, and it's easier to answer in exam. Chalo, good class.
Yes.
Okay, sir.
Thank you, sir.
Thanks, sir. Thanks, sir.
Thank you, Gagan.
சொல்லுங்க தேங்க்யூ அது போடுங்க. ஐயோ போறா. ஐயோ இவரோட எனக்கு டைப் பண்ண தெரியல. அவரு போயிடுவாங்க போல. தேங்க்யூ சார். பஸ். ஐயோ எப்படி போறது? முன்ன பின்ன சாட் பண்ணிட்டு தான் தெரிஞ்சிருக்கும்.